So since we didn't have there was no pre-conference on this set of unknowns, we're going to go ahead and start with those. Let's go ahead and give everyone a chance to focus. We're in focus on mine first. I see people still focusing. Everyone good? Okay, let's just make sure we're a little bit out of color there. Okay. So, let's start with this one. Shane, what do you think?
Neurofibroma.
Okay, so why neurofibroma?
Well, sort of got a like myxoid background and all the S-shaped or spindly cells in a haphazard arrangement.
Okay, so very good. So it's pretty diffuse, uniform, loose myxoid at scan, and you often have areas that are a little bit denser, a little bit lighter. You may have some preserved nerves within it, but the majority of it is loose myxoid proliferation that has all supporting elements of the nerve, to include Schwann cells, which tend to be curvy and S-shaped, mast cells, which look like these little fried eggs. So you're absolutely correct. And they tend to be strongly S100 positive, whereas if they undergo malignant degeneration, they're patchy and weakly S100 positive. So malignant peripheral nerve sheath tumor has pretty poor expression of S100. If you have something where you're thinking MPNST and it is strongly S100 positive, you're looking at a spindled melanoma. Okay, James, what do you think at scan?
Schwannoma.
Okay, why Schwannoma?
Because of the characteristic Antony A and B elements admixed.
Okay, so all Schwannomas are roughly round to oval. They are encapsulated. They tend to have a crescent-shaped zone of subcapsular edema, which is the Antony B. And then centrally is where you tend to find the Antony A, which is the denser tissue non-edematous, which often has the palisades of Schwann cells. Whereas neurofibromas have all elements that support the nerve. Schwannomas are Schwann cell only. So you usually don't see any axons in them, although you may have a nerve compressed over to one side, and because of that nerve compression, they are often spontaneously tender or painful. So they're in your England or Bengal group of, or blend and egg group of spontaneously painful tumors. But again, for histology, round to oval, crescentic zone of subcapsular edema, and then the denser tissue centrally, which often shows palisading verrucae bodies. Okay, so Christina, what do you see here?
So I see like larger nerve fascicles throughout the dermis.
And do they look like normal nerve, or are they sort of puffed myxoid nerves?
No, there's much more myxoid within it, and then like I'm surrounded by myxoid stroma as well. So it made me think more like plexiform neurofibroma.
Yeah, so there's plexiform neurofibroma, like a bag of worms, but the plexiform neurofibroma is embedded in diffuse neurofibroma. What would cause such a thing?
Like a malignant peripheral nerve sheath tumor or just neurofibroma as well.
So when you have plexiform embedded in diffuse neurofibroma, that's usually segmental and it's loss of heterozygosity, so you have no tumor suppressor gene left at all. So if you're born with neurofibromatosis, you have one allele that's absent from birth. If you have, as a postzygotic somatic mutation early in fetal life, so when you're a morula, you knock out one segment, knock out your remaining allele, you get one monstrous segment that has cafe au lait, spot, and diffuse neurofibroma, and plexiform neurofibroma all in that segment. So when you look at most segmental neurofibromatosis, it's postzygotic somatic mutation. If it's just little bumps of neurofibromas, you sporadically knocked out both genes in that segment. If it's really a monstrous segment with cafe au lait and plexiform and diffuse, that's always been considered pathognomonic for von Recklinghausen's, because you already lost one at birth, or at conception you lost one, you lost a second one early in fetal life, and you get that big segmental overgrowth. Neurofibromin mutation is one of the most common mutations in man. If you look at someone with neurofibromatosis, all those bumps all over their bodies is the rate of spontaneous mutation, because you need to knock out both to grow a neurofibroma. So they were born without one, and throughout their life they keep growing those bumps. Every one of those is a spontaneous second mutation. Every one of you has the same number of spontaneous second mutations. The only reason you're not covered with neurofibromas is you were born with two. So when you knock out one, you still have one left, which is all you need. The people who are just born with one grow a neurofibroma everywhere where they have spontaneous knockout of the second one. So segmental neurofibromatosis rarely can be a double spontaneous knockout. Vast majority of the time you were born with only one, you've knocked out a second one in a segmental fashion early in fetal life. Okay, Jessica.
I think it's a PEN.
So you're saying palisaded encapsulated neuroma. Why PEN?
Well, it's superficial. It looks like there's an adjacent sebaceous gland, and it's palisaded encapsulated.
It's superficial, and it's broken into these little fascicles of nerves with clefts in between. So PENs are usually superficially located, whereas schwannomas tend to be deep. It can be encapsulated, although usually it's not. It can be palisaded with little verrucae bodies, although usually it's not. It's probably not a true neuroma. So the old joke was, what would you call something that's not palisaded, not encapsulated, and not a true neuroma? Well, a PEN, right? But characteristically, they're vertically oriented, and they're composed of fascicles of nerve separated by clefts. So superficial, fascicle of nerve, separated by clefts. The palisade, the capsule, those things aren't required. Okay, so we're on the scalp. And then is this goodness or badness on the scalp?
Pretty ugly.
Pretty ugly. So tell me.
Small round blue cell tumor.
Say small blue round tumor. Go ahead.
Kind of like trabeculae.
And it has a trabecular growth pattern, which is the same as what in melanoma we'd call a parallel theque pattern, which are just these long parallel nests. And in a small, round blue cell tumor, our hypothesis is that trabecular pattern may be almost as good as immunostains. We're testing that right now. But when present, it certainly leads you towards Merkel cell carcinoma. And the old name for the tumor was trabecular carcinoma because of the growth pattern. So small blue cells, smudged, little cytoplasm. It's pretty much just nucleus. High nuclear cytoplasmic ratio, inconspicuous nucleoli, smudged chromatin pattern, trabecular growth pattern. Merkel cell carcinoma. Tend to be older people, head and neck, a little bit plum colored. Prognosis good or not so good?
Not good.
Not so good. Although we have a brand new drug just released for metastatic Merkel. Okay, how about this one?
This one I'm thinking about maybe a neurothecoma.
So neurothekioma certainly goes in nested theques. They're usually clear because of all the mucin. This thing is pretty pink.
Mm-hmm.
So it's pretty pink, and even at scan, you can see these things that are giant lysosomes sitting in a vacuole.
Is this just granular something?
So this is a GCT, granular cell tumor. So granular cell tumor, the first thing is the color. It matches the color of the erector pili muscle. It's usually pretty much right on what erector pili looks like in color. And because they occurred in the tongue and they were the same color as muscle, the old name was granular cell myoblastoma because they thought it was a primitive smooth muscle tumor. Immunostains came out, it's S100 positive, it doesn't have any muscle markers, it's a nerve tumor. But the granular cell tumor, you can still use that similar color as muscle as a hint. Other people, some of the residents have pointed out that it's about the color of everything Barbie owned. So Barbie's car, Barbie's dresses, Barbie's house were all about the color of a granular cell tumor. So kind of Barbie pink color, and when you look higher you see the granules, but already at scan you can make out those giant lysosomal bodies, which are the so-called pustulo-ovoid bodies, right?
The non-neural granular cell that has the different name, how does it look different?
So non-neural granular cell tumors are related, most of them, to plexiform fibrohistiocytic tumor, and they don't have the giant lysosomal granules. So that's the biggest hint at scan, is if you don't have those big giant lysosomal so-called pustulo-ovoid bodies, then it's then you start thinking of non-neural granular cell.
Looks like agral skin. I mean, think about that accessory digit. I mean, I think I'm seeing nerve tissue in there.
So looking, you see something that looks neuroid. Is it A, well-defined, mature-looking nerve in fascicles, or B, myxoid pools with stellate nuclei?
So the latter myxoid.
So shockingly, it's the second choice, right? And so what neural tumor is composed of myxoid pools with stellate cells resembling the nerve sheath?
So Schwannoma?
Or the nerve sheath. So if you were
Neuroma.
Greek and you were saying a sheath is a theque. So if you were saying a nerve sheathioma in Greek, you'd say a neurothekioma, which is the same as nerve sheath myxoma. So neurothekiomas come in two flavors. The cellular ones, which are probably not neural at all, they're another variant of plexiform fibrohistiocytic tumor, and they're S100 negative. And the strongly S100 positive nerve sheath myxoma which is the same as a myxoid neurothekioma. So neurothekioma, the name means nerve sheath tumor, and the true nerve sheath neurothekiomas are the myxoid ones, which is what we're looking at. And then the cellular ones are probably not nerve sheath in origin at all. Okay, how about this one?
Looks like we have some nerve tissue, solitary papule. So I'm thinking like a supernumerary digit.
Yeah, and in fact, this one is
Acral
even shaped like a finger, right? The fingernail should sit right about there, right? So this one even looks like a little finger. It's acral skin, and it differs from an acquired digital fiber keratoma in that it has vertically oriented fascicles of nerve and vessels. And it can have bone and cartilage and everything. It can be a fully formed digit, too. Okay, how about this one?
This one is arranged kind of in fascicles. It's definitely got some large pleomorphic nuclei. You can see it scanned.
And at the very scan, is it encapsulated or non-encapsulated?
It's more like a schwannoma look to it.
Yeah, so it's round. It's a big round ball that's encapsulated and has a crescentic zone of subcapsular edema.
With the big nuclei, I wonder if it's just a schwannoma with ancient.
But I see big, hideous nuclei. Wouldn't that be a malignant schwannoma? Don't malignant schwannomas come from schwannomas?
It's an old schwannoma.
Yeah, this is just an ancient schwannoma. So the old term malignant schwannoma, now what's now called malignant peripheral nerve sheath tumor. So malignant schwannomas, do they ever come from schwannomas? Probably never. They come from neurofibromas. Better than 50% of the time in a patient with von Recklinghausen. So someone with von Rex who has one neurofibroma that suddenly is big, hard, and growing is likely a malignant peripheral nerve sheath tumor, MPNST. The old name neurofibrosarcoma was probably the best name for it because it describes exactly what setting it arises in. Because it is purely the Schwann cell tumor that becomes malignant, unfortunately, for several decades, they changed the name to malignant schwannoma, but it made people think that it came out of schwannomas, and people with perfectly benign schwannomas with this ancient atypia ended up with amputations and horrible things happening to them, which is part of why they changed the name to MPNST. If they had just gone back to neurofibrosarcoma, people would remember what they arise in, which is neurofibromas more than half the time in the setting of von Recklinghausen's. So scan, encapsulated big round ball, crescentic zone of subcapsular edema, very pleomorphic atypical cells, but no mitoses. And that's just ancient change, which is in neural crest and smooth muscle lesions is a dime a dozen. Right? So in a leiomyoma, we saw them recently, we call the symplastic change. In a melanocytic or neural, we call it ancient change. It's all the same thing. Right? It's just that atypia in the absence of mitoses means not much in the setting of a neural crest or smooth muscle neoplasm. Okay, how about this one?
So this is pretty close to the epidermis. It might be encapsulated.
And is it broken into little fascicles?
Yes.
And does it actually have some parallel little palisades of cells?
Yeah, it looks like there's some varicate lines.
Yeah, so this is probably the world's only truly palisaded and encapsulated neuroma. So now you've seen one, which is where the name comes from, but most of them are not really encapsulated. And a lot of them aren't that palisaded. But you can recognize them by the vertical orientation and the clefts. Okay. We did those hit the key teaching points. one of the things you guys may want to consider is if this is the only year that they've done the pre-session early mornings like this. It's whatever works best for you. Whatever time works best to do it. It's just, we can cover more ground rapid fire, and if some of the basic concepts have been hidden in advance. Okay. So
Looks like a neurofibroma.
so why neurofibroma?
So it's all pretty monotonous, and they look kind of wavy from here, or dolphins jumping, kind of myxoidy in the areas.
Yeah.
And there's probably mast cells if you go down closer and look for them.
So kind of diffuse, myxoid, not broken into fascicles.
This one looks like a diffuse NF versus DFSP.
So diffuse NF versus DFSP. It looks diffuse, good for you. It looks diffuse, it looks myxoid. It infiltrates the fat in a DFSP type growth pattern where it's a very coarse honeycomb and then parallel strata. And you correctly pointed out that a myxoid DFSP looks just like diffuse NF on H&E. So how are you going to tell them apart?
CD34 and S100.
So CD34 and S100. CD34 is reliably positive in the non-myxoid areas of the DFSP. Kind of loses it in the myxoid areas, but it doesn't pick up S100. And so if it's S100 positive, you pretty much know it's a neurofibroma. You can also do something like a neurofilament stain, because you should see little nerve fibers randomly distributed in a neurofibroma. In a schwannoma, it's a nerve trunk compressed to one side. In a neurofibroma, the whole nerve has been popped like popcorn. And so the individual nerve fibers are spread apart, splayed apart. So you got one here, one there, in between all the myxoid stuff. And diffuse NF is pretty much pathognomonic for von Recklinghausen's as well, just like plexiform. Okay, how about this one, James?
I mean, this 2 looks like diffuse.
This too looks like diffuse NF with single file rows of lipocytes, but could it be a myxoid DFSP?
It could.
It absolutely could, and so the immunostains can help, looking either for nerve fibers, for CD34. Most myxoid DFSPs are recurrent, so the patient had a history of a prior tumor that was a DFSP. But important that they are lookalikes. Looks like the top of a neurofibroma, kind of diffuse, myxoid, jumping dolphins. But I'm going higher. There are some pretty large, dark cells. Some of them stellate, atypical. They look almost like radiation fibroblasts. Wouldn't that make this malignant?
I don't see any mitosis in there that would be potential for malignancy.
So are you telling me that atypia alone doesn't mean much in a neural crest lesion?
That's what I've heard. I wouldn't know.
So you've heard tell that atypia alone doesn't mean much in neural crest lesions. And sarcomas in general, especially translocation sarcomas, tend to be hypercellular rather than atypical, right? And this one is not hypercellular. So the key is no mitoses and it's not hypercellular. So first off, we're in parotid, right? That's glandular tissue. And so what is in this parotid?
don't say the perineuroma, but I don't feel like that would be in parotid.
So, and perineuromas tend to be onion skin fibrosis. Here I see area that still looks wavy like a nerve, but the rest of it is kind of puffing like popcorn where it's getting all myxoid and spread out. When I go back, I see multiple trunks, kind of like a bag of worms.
So like a plexiform.
So yeah, big myxoid plexiform neurofibroma, and that is, unfortunately in parotid, which means just by bad luck, the second fetal hit was facial. And those usually mean lifelong continuous plastic surgeries because it just keeps growing back. And it makes you want to pursue things like imatinib or anything that could shut down the growth of that tumor.
At first I thought it looked kind of pink like Barbie.
Yeah, except that, so it definitely has that pink color, but they're not granular.
So kind of epithelioids like cellular neurofibroma.
Yeah, kind of epithelioid, like you might think of an epithelioid histiocytoma, but those don't tend to be in little fascicles or theques. And the ones that are in theques or fascicles, the brings up the possibility of cellular neurofibroma. This one's making collagen, which is okay because cellular neurofibroma is actually fibrohistiocytic. It stains with, what kind of stains could you use to mark?
S100A6.
S100A6.
Factor 13A.
Sometimes 13A, S100A6 pretty reliably, NKIC3. Those are all things that are commonly used that they will stain anything histiocytic. So anything histiocytic or fibrohistiocytic. So DF, AFX, any of those things will stain with those. They're sensitive but not specific. I'm sorry, go ahead.
I was just going to say, this one's very well demarcated, relatively superficial. I think I'm seeing some dark areas. I don't know if it's just artifact or like some of the ancient change what we keep saying.
Yeah, so if you have scattered dark cells, you might think ancient change, but it's non-encapsulated but well circumscribed. It's diffuse myxoid. Makes you think of what?
Just a little line and a half.
Yeah, probably just a little neurofibroma from scan.
We have a lot of small round blue cells.
Small round blue cells, and are they growing in a diffuse pattern, or do they have any characteristic growth pattern
We
here?
have that trabecular nested.
A trabecular nested pattern makes you think of
Merkel's.
Merkel, so you'd want to do Merkel markers. So tell me about Merkel markers.
Synaptophysin, chromogranin, neuron-specific enolase, CK20, paranuclear.
So CK20, a paranuclear dot. Pretty much any keratin can do the paranuclear dot, but the CK20's a little more specific. You lose actually a little sensitivity. So if CK20 is negative, sometimes just a pan-keratin will show you the paranuclear dot. And then more specific stains like synaptophysin, chromogranin, and what used to be called still is called neuron-specific enolase, but it's so non-specific that people jokingly call it non-specific enolase. Okay, how about this?
So kind of a diffuse proliferation of nerve tissue.
Yep.
And infiltrating the fat. I mean, we just think about like a diffuse neurofibroma.
Are the nuclei jumping dolphins, or are the nuclei round.
Round.
And then the cells themselves, why are they so grainy? One might even say granular.
Granular cell tumor.
Do you see giant lysosomal granules?
I don't.
How about that round thing at the tip of the arrow sitting in a vacuole?
Yeah.
There,
Very subtly.
and here. So they don't pop quite like the ones, but they're present in the last case, but they're present, which would lead you to probably a neural granular cell tumor rather than a non-neural one.
Looks like it's probably another ancient one.
So, like, it certainly has a
Can't
lot
sleep on
of
past eccles.
certainly has a lot of atypia, but this one has mitoses as well. How comforting is that for?
Not. I'm on this history. Do they have a plexiform NF? Do they have history of NF?
Well, it's a patient with von Rex, and now there's a big hard mass.
Yeah, so MPNST.
So MPNST, you'd expect some areas to be a little hypercellular. It does change its pattern from something highly atypical to something that's more spindled and cellular. Now this one, it's not really infiltrating muscle. Instead, it has muscle differentiation within it. So you have this ugly-looking nerve tumor and fascicles, and you have striated muscle differentiation within it. Looks kind of like a salamander when you cut its tail off and it's regenerating a new tail.
Which we're all
So the old family or genus name for salamander type organisms, they're Tritons. And so the Triton tumor is an MPNST with striated muscle differentiation. And named that because it looks like, sort of like the regenerating tail of a salamander, having the nerve and the muscle. So muscle, and the muscle is usually benign. Occasionally you can see malignant muscle, but usually the muscle is benign, the nerve component is malignant. So smooth or striated muscle differentiation within an MPNST is Triton tumor.
I thought that the Triton tumor was supposed to have the rhabdomyoblast and not fully mature striated muscle.
You can, I've seen, well, let's read about it. I've seen, it's a rare tumor. I've never diagnosed one. I've only had them sent to me in clubs. And they've had immature muscle and they've had ones with mature muscle. So, but let's read and see what the books say. Okay.
This looks plexiform, and there's a background diffuse NF, so it's probably plexiform NF within a diffuse NF.
So plexiform NF within a diffuse NF, which would mean the patient has
Von Rex.
von Rex. Okay. Let's see if we can find.
So this looks like balls of nerve fascicles.
And is it a single vertically oriented superficial
No.
thing like a PEN?
Nope, they're more individual fascicles and multiple fascicles. So I'd be thinking more like neuroma.
Like a neuroma, and neuromas are most commonly where on the body?
Acral.
Acral, and it looks like acral skin. And it's usually a true traumatic neuroma. It's broken into fascicles like a PEN, but instead of being superficial, vertically oriented, small, it's big, deep tumor. Okay. Let's see.
looks very myxoid.
Looks very myxoid, and I see stellate nuclei and blood vessels. So do you know any omas of mix?
Like a myxoid neurofibroma.
So it could be a nerve sheath myxoma or could just be a myxoma, right? And so how would you tell the difference between a nerve sheath myxoma and a regular myxoma? Any stains you could do?
Yeah, so S100 stain.
Yeah, so if it's S100 positive, then it's a nerve sheath myxoma. If it's S100 negative, then it's a regular myxoma. Any syndromes with nerve sheath myxomas?
Yeah. Carne complex.
That's usually the regular myxomas, yeah. So not so much with nerve sheath myxomas, but if it's regular myxoma, then you have to see, do they have Carne complex? Because they could have a true medical emergency with a huge myxoma flopping around in their heart.
Okay.
So, well done.
Is there a syndrome? Did you just say?
I'm sorry.
Okay, so there's not a syndrome.
Not with not nerve, not the neural ones, not the neural.
It's like really superficial nerve-looking tissue there.
So superficial, and if you had to describe a vegetable that has similar concentric pattern.
Perhaps like a leek.
That's the one I would have gone for, or anything in the allium family. Yeah. So if the people involved had been better cooks, it would have been a leek or shallot pattern. Unfortunately, they were sort of workaday cooks, so it's referred to as an onion skin
But I don't
pattern. Okay, so this shallot pattern tumor, what would this be?
Oh, perineuroma.
So a sclerosing perineurioma, if it is confirmed by immunostaining with what? So perineurium stains with
No, this one.
EMA.
EMA.
So epithelial membrane antigen, EMA. So the normal perineurium is EMA positive. Perineurioma is EMA positive. You can occasionally have myxoid perineuriomas, and you know that it's not a nerve sheath myxoma because it's EMA positive instead of S100 positive. And you have sclerosing perineuriomas, and they have the shallot or leek appearance with the EMA positivity. And if you have, going away from this tumor, if you have a desmoplastic melanoma, and you want to know if it's perineural involvement or not, you get two immunostains. You get either an S100 or SOX10 paired with an EMA. Normal nerve, the nerve itself will be strongly S100 positive. The perineurium will be an S100 negative perineurial sheath. If that perineurial sheath is S100 positive, you're looking at desmoplastic melanoma. So when you're doing Mohs for a desmoplastic melanoma, SOX10 can be done on frozen tissue. S100 can be done on frozen tissue. And so you track those nerve trunks until your perineurium is no longer S100 positive, and that's when you're cut beyond the desmoplastic melanoma. The problem with desmoplastic melanoma is they behave like facultative fibroblasts, and they start to behave like perineurium. and they go along the nerve, and on H&E they can look just like perineurium, except they're S100 positive, EMA negative. And until you've cut beyond that, you're going to get recurrence. Okay, so we're on the scalp, and then down in the scalp, you have that vaguely myxoid, neuroid-looking area, but it's also dissecting between collagen bundles, making almost vascular-looking clefts.
Pseudovascular spaces within it, so it'd be consistent like a meningioma.
Yeah, like a rudimentary meningocele. So rudimentary meningocele tends to, the meningothelial cells wrap around things, wrap around collagen, form an angiosarc-like pattern dissecting between collagen, and sometimes they're more neuroid, myxoid, almost NF-looking areas. And then true meningiomas form meningothelial whorls, which are these little whorls. They also wrap around things. They tend to be fairly bland epithelioid-looking cells. So true meningiomas, which you will sometimes get ectopic, but more commonly when you see it in skin, it's eroded through the skull. And you're seeing the tip of the iceberg. Meningothelial whorls, epithelioid cells, you probably don't have to diagnose them, but you need to know they exist, right? You need to know things you can get into trouble with. The world doesn't just consist of the things that are common in skin, and so you have to know when you're potentially out of your realm. Okay, what would this be on acral skin with vertically oriented nerve fascicles and vessels?
A accessory digit.
Supernumerary digit or accessory digit. Very good. Okay, patient has a midline lesion on the frontal scalp, but you are fearless, and so you excise it. Who needs imaging studies? And you send it to path, and you have this glial tissue that looks pretty much like white matter. What have you just cut into?
Glioma.
Yeah, or in this case, true brain. So you have just performed, you took out that cyst, and you have just nicely performed a frontal lobotomy on that patient, which is why, congenital midline lesions.
How do you build that?
How do you build that? Thank you. That would be the relevant question here. Exactly. Thank you. Okay. Okay.
A lot of hemorrhage into this little...
A lot of hemorrhage into it. And what's its overall shape?
It looks like it's one or maybe two large fascicles.
Yeah. The whole thing may be round to pretty long oval. Encapsulated or non-encapsulated?
Looks like it's got a little capsule.
And just a little hint of subcapsular edema. Anything neural that could be encapsulated round to oval with subcapsular edema?
A little schwannoma.
Can schwannomas be aneurysmal and bloody?
I hope so.
Yes, they absolutely can.
That was the heart.
Yeah.
It's just how this will break.
Let's see. So it kind of has the pink color of a granular cell tumor, but it's not quite as nested as I would like.
And what are all these Vericay bodies doing there?
Yeah.
In
So
something that's superficial, kind of vertically oriented and clefted.
So, I mean, I think I could talk myself into some subcapsular edema, maybe like a schwannoma.
But it's
Or-
not deep circle encapsulated. It's fascicles with clefts between them. It's just the fascicles are fat because of all those Vericay bodies.
So it's a neuroma.
So it's
PEN.
PEN, and some of them really can be palisaded with lots of Vericay bodies. So spectrum of PEN, they all tend to be vertically oriented. They all have clefts between the fascicles. They're all superficial. Some of them are actually palisaded like this with Vericay bodies. Some are actually encapsulated. This one not so much so. But it sure lives up to the palisaded part of its name, which they can.
So, first thing that stands out is it's pretty pink.
Capsule yes, capsule no.
Yes.
Subcapsular edema, yes or no?
Yes.
So I see something that is encapsulated with subcapsular edema. What should be the first thing that I think of?
Like a PEN? No. Schwannoma.
Schwannoma, exactly. And then does it have the more edematous tissue to the outside and the denser tissue to the inside? And then you start to look, can I make out any palisades in the center? So, but the basic architecture, this one is not that well palisaded. Doesn't have great Vericay bodies, but it's a deep encapsulated tumor with subcapsular edema. So for a derm resident, I think a fair thing to ask you would be one that has Antony A and Antony B. For a Dermpath fellow, you should be able to nail the ones that are soft schwannomas that are only Antony B. And what they look like is a big, deep, round to oval encapsulated mass with subcapsular edema, and then less edema but edematous throughout, and no Antony A. And that's what a soft schwannoma looks like.
I just wanted to see that one.
Oh, okay. So this is kind of vertically oriented and epithelioid. The vertical orientation is some hint that it may be nerve. When it's epithelioid like that, you could think of neurothekioma. You could think of one that's not neural. You could think of a epithelioid histiocytoma. So you're going to look for things like, is it 13A positive? Is it staining fibrohistiocytic? Is it staining neural? If this one is S100 positive, then you'd put it in the neural category. And it's certainly epithelioid. This one may actually be an epithelioid PEN by its architecture, even though the person who signed it out called it an epithelioid schwannoma.
So a true epithelial schwannoma would have all the other characteristics.
Would have all the other characteristics of a schwannoma. Yeah, this is probably more of an epithelioid PEN.
Yeah,
Okay. Let's try to go rapid fire. So,
looks like we're on the scalp.
looks like we're on the scalp.
And we're missing hair in the middle, and there's the big cleft-like space.
And it's dissecting between collagen.
It's probably rudimentary meningocele.
Probably a rudimentary meningocele.
Looks kind of like a neurofibroma. It's somewhat large. It's not quite hitting a diffuse NF.
It looks kind of like a neurofibroma, not quite hitting a diffuse NF. It's certainly not going down to fat. It is making these kind of whirl things. And when you stain it, it's not S100 positive at all.
So it could be the meningocele as well. Or it could be like a perineural.
So it's EMA positive. which would be both meningocele and perineurioma. With the perineurial whorls, probably more perineurioma-ish. One of the things that could help is you do a neurofilament stain, and in the very center of that onion skin, there you'd find that the whole thing is wrapped around a tiny little nerve twig.
So
Let's see, that's all we get is that piece there.
looks kind of acral. Looks kind of spindly.
Yeah. And I would assume that this was EMA positive and S100 negative.
Then it's a perineurioma.
Yeah, that's what they called it. It's a little less perineurial than some. Sometimes you go on the immunostains. This one was also called a perineurioma. I would go down. That's what they called it. I would go down a much broader differential. I can see that some things here are concentric, and some are myxoid. There are soft tissue perineuriomas that look different from what we usually see in skin. I think you had one in the fellow unknowns, but I would definitely walk through immunostains for this and get a consultation. Doesn't look like the ones we see in skin. Okay. Does the body like this thing?
No.
So when you have something that is producing collagen and has lymphoid aggregates, what's the first thing you think of? Like a desmoplastic melanoma, absolutely. And this is actually S100 positive, but when you look through it, there are these poorly formed granular cells. It probably doesn't matter if you're calling it a DMM or a malignant granular cell tumor. Behavior is going to be pretty similar. What are the hints that granular cell tumors are malignant? Size, and size would be the first important ones. And why is so much attention paid to size? Because often they don't have mitoses that you're picking out, and they don't have that much atypia. They're just big. And when I was a resident, when I started my residency, all the textbooks said 8 centimeters or more. And by the time I graduated, they said 5 centimeters or more. Then they said 3 centimeters or more. Now they say 2 centimeters or more. Basically, people keep getting burnt on things that behave like malignant granular cell tumor that were big but not huge. So a big granular cell tumor needs to be completely excised, is the moral of the story. Okay, how about this thing? Where are you?
Change the me or you? Did you do the last one? Cool. Scalp.
Scalp, very good. Scalp. And you've got something on scalp that is kind of loose and myxoid in most areas, but in some areas it seems to be making some clefts and kind of wrapping around a big collagen ball there. You know anything that might do that?
I mean, not like a meningocele.
You get credit for the jeopardy, posing it as a question. Very good. It is indeed like a meningocele. Okay, so we've got a lot of scar, and embedded in that scar, lots of nerve fascicles, and it hurts like crazy, and it's where an amputation took place. Like a traumatic neuroma. Very good. Like a neurofibroma. Some areas that are a little denser, a little looser, but overall loose, myxoid, wavy, jumping dolphin cells. But I do see some larger hyperchromatic cells in there. Should I be worried?
I don't think so.
Okay, in the absence of mitoses or hypercellularity, the atypia doesn't mean much. Okay, let's see what else we got to hit here. So that's the skin.
So like a granular cell tumor.
Like a granular cell tumor. Why granular cell tumor?
Because it's pink like Barbie.
Because it's pink like Barbie,
It's
so
got large eosinophilic cells.
it has large eosinophilic granular cells. And do you see any giant lysosomal bodies?
Yes.
There are some. There. Let's see if we can get. You see that guy like right there? Yeah. So there are some giant lysosomal bodies. So you might still want to get an S100, but probably a granular cell tumor. And then, what do you want to know about that granular cell tumor if you just have a piece of it?
How big is it?
How big is it? And well, it's moderately. Maybe it's around 2 centimeters.
Probably take it out.
Yeah, make sure it's completely out. Okay, how about this one?
Good call.
A schwannoma?
So it looks like a schwannoma. It's encapsulated. Each one has a little bit of subcapsular edema, is encapsulated, has varicate bodies, but why would it be plexiform? Is there such a thing as a plexiform schwannoma?
It's exactly that.
Yes. Yes, there is. Okay. How about this? What would give you these pools, these myxoid pools with stellate cells?
Is it a nerve sheath myxoma or just a nerve myxoma?
Yeah, nerve sheath myxoma. So nerve sheath myxoma, which is the same as a myxoid neurothekioma. How would you expect it to stain?
S186.
S100. And it also may do S100A6, may not. It's the cellular ones that do S100A6. Okay. How about this big encapsulated thing with a zone of subcapsular edema?
Schwannoma.
Schwannoma, very good. But what you should have said was, schwannoma, don't waste my time, right?
Right.
So this one is cellular.
Yeah, so it's a little cellular, right?
Yeah, I don't see any mitoses.
So this one, you might look for mitoses. You might get Ki67, get a PHH3 looking for mitotic figures because it looks like neurofibroma. It's getting a little cellular, so you might want some help looking to see if it's proliferative. Tell me about the color.
It's pink, like
Pink.
Barbie.
Pink like Barbie.
Sort of could be granules down there. Everyone would take a look. It's in fascicles and kind of theques.
Yeah, exactly. So, you'd probably want to look, based on the color, you'd want to look a little higher, see if it's granular, see if it has giant lysosomal bodies.
It looks polypoid.
Looks
I think
polypoid.
there's nerves in there.
And there are
so
nerves in there.
Accessory digit.
Accessory digit, supernumerary digit, nidget, any of those names.
So they're like myxoid fascicles, but just deeper.
So deeper, but with myxoid fascicles, with stellate cells.
It's like a myxoid.
Like a myxoid neurothekioma or nerve sheath myxoma. What stain?
That's one.
Okay. And last one, just to walk you through it. This is a cellular neurothekioma. It's cellular. It runs in theques. It's S100 negative. It is usually S100A6 and NKIC3 positive. They sometimes either trap or make little bits of ropey collagen because it's truly a fibrohistiocytic tumor. Okay, good.
Yeah, I did my research.
Did we go through all those? Did we go through all those?
We did go through all those.
You weren't with us about a month here?